Welcome to Making Therapy Better, the podcast that brings together some of the top minds in psychotherapy and related fields to talk about how we can achieve better mental health care for everyone. Making Therapy Better is hosted by Professor Bruce Wampold, who has dedicated his career to understanding how therapy works and advocating evidence-based methods for improving outcomes. His guest today is Zac Imel, PhD. Zac is a professor and director of clinical training in the counseling department at the University of Utah, as well as co-founder and Chief Psychotherapy Science officer at Listen.io, an AI-powered assessment platform for behavioral health and human services. He has had over 50 papers published in academic journals with a particular interest in assessing and improving the quality of mental health services in a variety of settings. Making Therapy Better is brought to you by CarePaths. CarePaths has been helping in-person and virtual therapy practices thrive for over 20 years with their complete web-based EHR and practice management platform. CarePaths provides free tools to help therapists as well as clients benefit from the power of measurement-based care to improve therapy outcomes. Visit carepaths.com to start your free trial, and clients should look for the free Making Therapy Better app, now available for iPhone and Android. And now, without further ado, episode 20 of Making Therapy Better, How Can AI Help Improve Therapy? With Zac Imel, PhD.
So, Zac, it's great to see you today, have the chance to talk to you. The audience may not know that you're my former student, PhD student at the University of Wisconsin, collaborator on much research. Unlike some of my students, you've chosen a different track here. So you are an academic at the University of Utah, but your primary interest is in using natural language processing to improve the quality of therapy. And the platform for doing this, Listen.io, Lyssn.io, is a natural language processing platform for evaluating psychotherapy. So that's in a nutshell, but I want you to talk more detail about what this platform does and how it can be used to improve therapy.
Sure. Great to connect this way, Bruce. And I mean, yes, I guess I've had somewhat of a non-traditional path. It didn't feel like it at the time because I was really just pursuing interests. And what I would say is this really comes out of what I feel like I started to learn from you when I was hanging out in Madison, which was there aren't all that many new ideas in psychotherapy. We are drafting off of, eternal wisdom at some point, and we are trying to use the scientific method to understand it. And if anything, what's going to really take us forward is new tools. And what I felt like I got introduced to in graduate school was the current advanced quantitative methods of the time, right? And that I learned how mixed effects and multi-level modeling could really be applied to the current standard problems of the day and how they could clarify things that were really hard before. And the problem about becoming an academic is once you graduate and go out on your own, you got to figure out what the next thing is. And to me, I was a postdoc at the University of Washington at the VA in Seattle, and started hanging out with people who were playing around with, I wouldn't call them necessarily early versions of natural language processing, but they were certainly early versions of what everybody's freaking out about now. Mm-hmm. And I feel like if there's anything that we did that was smart, was that we could see the path that was coming. Whereas like these technologies were going to get better. And we are interested in inventing the kind of core language technology that would drive the future of understanding how psychotherapy works and how to improve it. And so it definitely started out with an interest on how can we use these tools to understand, right? Mm-hmm. We've got millions and millions of conversations happening, and functionally that's just a black box. And if you've got a mental health problem more or less, you get a pill or you get a conversation. Often you get both. And with the pill, hopefully someone in a lab somewhere in a factory has done the job to make sure the thing that's supposed to be in the pill is in the pill. And then if you get a conversation, it's not synthesized until you're actually in the room talking to the person. And so that to me is the core problem of trying to understand what matters in psychotherapy. And you can take different theoretical perspectives on what the answers to those questions are, but the methodological problem is the same. And so it's how do we start to build tools that open up the black box of the conversations people are having, allow people to learn from them, make systems more able to have visibility into what they're doing so they can improve it in whatever way makes sense. And so that's what the company we've done is really targeting. How do we, go ahead.
Well, it's interesting, Zac. When I was in graduate school, I worked with Galen Margolin on coding videos of couples interacting. I applied that to psychotherapy sessions. So we were studying at a micro level. But just to give some perspective on how we've advanced, John Gottman, who was kind of a leader in coding marital interactions, said it takes 100 hours to transcribe and code 1 hour of interaction. So we've come a long ways since that, because now it's done, I guess you could say, instantaneously or pretty close to it. So
we just published a paper in JAMA Open Journal that had 20 million conversations in it. The response letter took longer than the analysis, right? So, and so it's not that it doesn't solve all your problems, but in terms of scaling the observations of things that humans could measure reliably, it does a pretty good job.
Yeah, and probably more reliable because we trained coders, and that was a tremendous effort to reach some kind of reliability. Revisions of the coding system, training of the coders, getting rid of coders who couldn't meet criteria, all of that's gone away. So I think what we need to know is, how can this technology, how does Listen take this technology and provide useful information? So what kind of information? Just give us a flavor, some of the examples of what Listen can do.
Maybe I'll start with some really, really it's not simple, but kind of the stuff that's the most simple. And I think is one of the areas I'm most excited about, because it feels like low-hanging fruit, even though it maybe in some ways it's not. So we have a project right now funded by NIMH to build tools that support crisis counseling. And so if you know anything about what's happening in crisis counseling right now, there's a massive influx of support and funding into the 988 world to make sure that we can provide crisis services a lot more immediately and at a scale that really wasn't possible before. Attached to a lot of that money is you've got to actually monitor what some percentage of your crisis counselors are doing. And crisis counseling is a kind of constrained form and simplified form of regular counseling, right? It's very brief, but during the conversation, the goal is to try and first understand what's happening. So you do a risk assessment, right? You ask, have you thought about suicide? Do you have a plan? What's your intent? Do you have a history of those sorts of things? You do it hopefully in an empathic way. You ask open questions when you can. You do reflections where you're trying to make sure the person feels understood. So on each of those things I just listed, Listen has metrics that can tell you whether or not they've occurred. Mm-hmm. So we build labels that can try and understand, did the therapist ask about whether or not the person has a plan? Mm-hmm. And so the way we do that at a concrete level is first, the irony with some of this is we got into this work because we really didn't want to train coding teams, humans. And what we
Yeah.
actually do is train lots, and we have a full-time coding team that's running all the time with people who are doing all sorts of stuff. We do have ways of augmenting that work technically and doing some active learning where the model makes suggestions, but it's still a bunch of work. So we have human beings who label crisis counseling calls for whether or not the crisis counselors were doing these specific things that they're supposed to do in every call. And what we do know, crisis counseling is really hard work. It often falls to some of the people in our system with the lowest amount of training, sometimes relatively no training, right? Volunteers who are willing to go work in a church basement and just want to be helpful. And so that corresponds to just really high levels of variability. And what you find when we do research on crisis counseling is that there's tons and tons of calls where nobody asks any questions about suicide at all. Or they do things in a way that's really just not very supportive and empathic. And so we have human beings label those things. We feed those into current cutting edge machine learning models, train the models to recognize them at the same level of reliability that a human can. And it's not maybe one thing that's important for folks who are listening who are just new to this technology. The old school technology 20 years ago, there's some people who are still doing this, but it's dated at this point, would be just finding word matches, right? So did you say the word plan?
Yeah.
Right? Did you say the word suicide or harm yourself or something like that? These models are a lot more sophisticated to the natural flexibility in how people actually talk and can respond to different types of context and are much more able to recognize the way this language occurs. And so we can train these systems to be functioning at the level of human reliability, sometimes better. But where you really get the benefit is over time, where human beings get tired, they get bored, they drift, you have to retrain them. Usually they quit because it's not fun work to do this sort of stuff, where the models don't get tired and they can code instead of a crisis counseling system coding maybe 3 or 1% of the conversations they're having. We can do 100%, and we can give you complete visibility into the types of conversations that are happening that really allow you to target who are the counselors in my workforce that really need support, where we're trying to do these sorts of things and people are disengaging from calls with them really quickly and we don't understand why. We can go in and find, okay, well, what is exactly happening in these calls without having to just kind of go fishing in the dark.
So there's so many things to talk about, but I think one point that's important to emphasize, that the model building, the machine learning, really is informed by these human coders. So we know what's important in these calls. It's a risk assessment. It's an empathic stance. So you're showing both understanding, assessment, and then, so anyway, these components are identified by humans. I mean, we design these interventions and we know what they look like. But the machine then learns from us humans and can do it much faster. And as you say, maybe more reliably.
Yeah, I think the thing that the current generation of machine learning models is really good at least the ones we're talking about right now, are pattern matching, right? And so if what I think can be limiting in the world of psychotherapy is there's a lot of things that were probably important that we don't measure very well. Right? Humans don't measure them very well, right? Like the nuance of transference or some sort of like a behavioral chain analysis in DBT, or like, I mean, you could think about all these different kind of complex unfolding interventions that therapists learn that when you actually subject them to a coding system, it's really hard to do reliably and to get two people to agree. And when you don't have that with this sort of system, when you have two human beings who look at the same thing and go, that was yes and that was no. And if you've ever been to a psychotherapy conference, Bruce, and I know you have, the best way to get entertained is to put an expert on the screen and have them do something that is supposedly good, and then see half of the audience kind of look to their neighbor and be like, oh my gosh, that guy's awful.
Yeah, I'm smiling because I've been at hundreds of these, by not just psychologists in training, but experts, real luminaries in the field, arguing about the quality of what just happened. So,
yes. And so a lot of the work really is in, is there a system where there's some agreed upon way of defining the behavior in a way that people can agree that, yes, that's it. Now, whether or not that particular behavior was good in that context or should have been used, those are often more complicated questions, right? Where it's a little bit like, listen, at this point in its development, for the most part, it's like if you're, how to describe it? I can tell you whether or not the sandwich you ordered is a hamburger or a chicken sandwich or a steak, but I can't tell you what you should have ordered.
yeah.
Right? Like it's like we're classifying, we're a classification engine at some level at this point, and so we're using human knowledge. And the thing that's cool about current transformer-based large language model machine learning is they do a really good job of learning from prior stuff that's just kind of out there on the internet. So they learn basically like a latent understanding of human language and how words and meaning fit together. And then you fine tune that on a particular problem. And a lot of what people have gotten nervous about with large language models is if you don't do that fine tuning step, they can be awfully compelling and awfully wrong, right? So they'll give you confidently wrong answers. So what you really have to do if you want to use this stuff in a medical clinical context is you need to be doing validation that makes sure we're actually doing what we think we're doing.
Well, let's get to the validation question, because that was on my mind. And I know you've thought about this and done some work in this. We want to be able to identify, or I should say, validate that what we're measuring is actually related to outcome. Yeah. So we might be able to reliably assess what's going on in a therapy session. But unless what we're assessing is related to the outcome, it's pretty worthless, is it not?
Well, yes. I mean, I think framed simply, yes, right? Like if you just thought, if I was to develop a measure of, how many times, because we have one of these skills is how often did I structure the session, right? So that's a behavioral code in a lot of different systems. Whereas part of what you're doing in a CBT session, or even sometimes in an MI session, is providing some framework for like, what are we going to do here, right? And we don't have a lot of good data at this point that suggests like doing that structure intervention is absolutely essential. And it's also hard to imagine sometimes like not doing it, right? Like, because it feels sort of like table stakes in the conversation when you're setting up the conversation. So I don't necessarily want to say correlational research as we're doing it right now for like saying X, Y, or Z behavior is related to outcome is still somewhat limited. At the same time, so just take the paper I was mentioning a little while ago. We did an analysis with Talkspace, who we partnered with. We had 5,000 therapists. It was around, I'm going to get the number wrong, 150,000 clients, something like that, 20 million conversations or so. And we were able to label, we had the transcripts for every one of those conversations that had been de-identified. We were able to label something like 54 different things that happened during those conversations, from empathy, active listening, advice giving, different types of CBT interventions, all that sort of stuff. And then we had how much engagement, how many weeks did they stay in care, how satisfied were they with care, and then reductions in PHQ. And so what we generally found in that data set, in this is, talks-based, text-based kind of conversations, it's a different sort of way of providing treatment. The things that we often in the common factors world think matter were the ones that sort of mattered, right? So like empathy, reflective listening, particularly complex reflections, which are a subset of reflections and motivational interviewing that are not just parroting, but are really working hard to try and see behind what the person is saying and offer a little bit extra, they can have an interpretation-like quality to them. Those sorts of behaviors were the ones that were correlated the most with satisfaction, engagement, and reductions in distress. Whereas in this particular case, we just really didn't find any evidence that CBT-like things were correlated with outcome. Now, my good colleague Tori Creed at Penn was a co-author on that paper, and I know she would say, I'm not convinced that means that, using high quality CBT in all sorts of other contexts is going to be unrelated to outcome. And she has a really good argument for that. Like, even if 30% of the adherence measure for CBT is common factors, right? And so it would be very, very surprising to me if adherence to CBT was absolutely not related to people getting better, because a good chunk of it is like interpersonal effectiveness, instilling hope. Like, it's all like this good stuff in psychotherapy. And so I think this was a long way of answering your question. We are focused on building measures of existing evidence-based treatments that have been shown to be helpful to people. And then we are interested in providing feedback to people on those things so they can help build their skills and understand what's happening. But at the same time, we're also interested in doing research on, now that we have tools that can scale process outcome research in a way that really just wasn't possible before, where, if you were to take there's an analysis that I know, Bruce, like I think it's Webb et al., 2008, maybe, something like that, where it was the first meta-analysis of correlations between CBT adherence and outcome, and didn't, basically found zero correlation. But the study, like the average study size was 50. Yeah. And so that's just not a great literature base to base strong claims about. And so I would love to see a future where the standard way of doing a clinical trial funded by NIMH is, you record 20,000 sessions and we can analyze every single one of them and get into really complicated models, nesting within providers, like utterances over time, to where we can start to ask much more detailed, specific questions that we haven't really thought about yet.
Well, what you're presenting is a sea change in the research world, especially the process outcome, because you're right, we've been limited to very small samples, and they're usually collected in highly specialized environments, university clinics, sometimes in natural environments, but small scale. And what you're saying, if you really want to know what works in therapy, you're going to get a much more sophisticated answer to that using thousands of interactions rather than a few. So that's exciting. As someone who's been doing process research for 40 years, everything we've done may be preliminary in a few years, which is a good thing. I mean, that's the way science progresses. So we have a change in our telescopes. We can detect things in outer space we thought were there, but we've never observed. And now we can do it.
That's the biggest problem with psychotherapy research of the past 75 years is we've had the same darn telescope.
Yeah.
Which is humans, right?
Human coders.
Yeah. Right. And we started to emerge better statistical models for putting that data together. But really at some point, we were correlating, alliance ratings or very small number of observer ratings. And we need a better telescope if we're going to understand something as complex as two human beings talking over the course of an hour, which is just, tons and tons of data from one conversation.
Yeah. So, one of the limitations, of course, is we don't get from those analyses you've talked about the phenomenological impression of the participants. And especially, we know patients' view of what happened in therapy is a good predictor of outcome. So it's a big leap, but we still have some room to go.
A couple of things, really. You're right. And so I don't necessarily have a disagreement with that. The thing I would say is that a patient or client's experience isn't necessarily inaccessible to some of these tools.
Yeah.
It's different and it's going to be harder, right? And so just take, for example, we published a paper with Simon Goldberg, who is the lead author at Wisconsin, where we built some of these models to see if we could predict an alliance score. Right. So it's the same type of process. We had the recording of the entire conversation, and then we had a rating of the client on how they felt about their therapist. And there's a brief measure of that. And there was signal there, but it's a lot less clear because you're moving from assessing something that was literally directly observable in the conversation, right? Was this an open or a closed question? Was this a reflection? Did they do X, Y, or Z? To essentially like what's in the client's head, right? How are they feeling about that? And you're assuming that there's some evidence in how they were feeling about this in the conversation. But what we also know from a lot of the multi-level modeling work on the alliance is a good chunk of the variability in alliance measure is literally about the client. And it's going to be hard if we don't have a bunch of information to get those things out. And the same thing, my student Patty Kuo, who's now at Penn on a postdoc, is one of her last papers she published before she left was, can we just predict the PHQ score in the next session from the transcript of the session with no other information, right? So we don't know no measures of therapist interventions, just literally taking the conversation, and can we predict what's the actual distress rating of the client afterwards? And the answer is yes, we can, right? We can make a guess about how you're going to feel in the next session from how this conversation went, but it's nowhere near, a correlation of 0.5 or 6. It's more like 0.2, right? And so
as you say, there's some signal there, but we'll get more sophisticated in terms of coding emotional expression, coding nonverbal actions in the therapy session. So in a sense, we're just beginning that journey into understanding more subtle cues of what's going on in a therapy.
And I think I think there's a path towards using these sorts of tools to get at patient experience. But I do think, I'm not necessarily looking for a future where we're not doing experiential research on what actually happened. I think asking the client how it went for them is a thing we should keep doing. Right?
Yeah, agreed.
And so to me, it's not that was bad research, and that was most of my research I did before we got into some of this stuff. I just think we need to be complementing it. And we shouldn't be relying solely on the client, who is the person in distress and coming for help, to tell us whether or not this was good. Right?
I want to shift gears here a little bit, Zac, because I think there's a critical question here. So, I'm very much a fan and impressed by the work you're doing and the work of others in this space. So I spent a lot of time in my career trying to design ways for therapists to improve. Okay. The research that Simon Goldberg, who we all know, has done is that therapists over the course of their careers really don't improve. Okay. Overall. So, Mike Lambert and Ken Howard had this idea of providing feedback to therapists about the progress of their client would be helpful to the therapist. And it turns out that's the case. In clinical trials, we know routine outcome monitoring or measurement-based care is an important practice for improving the quality of care. The problem is therapists, for a variety of reasons, really do not use measurement-based care in their practice and don't benefit from it. There's structural reasons, they're busy, there's the tools for doing it, systems, they cost some money, but it hasn't been overwhelmingly accepted as a practice, even though you could say it's an evidence-based practice. So, I can see all this data is really important. What impact does it have on the therapist to use this data? And how do they get better? When I say better, how do they gradually become more effective?
Great question. And I have a number of reactions to it. Like one is like, why is it that routine outcome monitoring isn't standard? Because it's probably like if you could get one thing that pretty much anybody in the formal scientific study of psychotherapy would agree we should be doing, no matter what your perspective is, it would be that. And you can't do much else until you do that, because it's like, how are we going to know if any of the other things we're doing are any helpful if we're not doing those things? So I think that gets into kind of much more regulatory and political and business related questions that I think are interesting and we could talk about eventually. But how does giving a therapist this sort of feedback improve their help or the help they provide, I think is another question. There's a couple layers you can answer that at too. And so maybe at the highest level, if we just kind of start theoretically, which I think most folks maybe listening to this podcast would be aware of, Daniel Kahneman just died recently. And one of the main things I was aware of his work, or I know he did lots of things, but the piece I was most aware of on his work on expertise and the work related to, if you don't have a definable behavior with reliable feedback, it's very, very hard to develop expertise in that thing, whatever it happens to be, right? And so I tend to think of all of these different types of practices we have in psychotherapy as ways of sort of packaging and instantiating all the good stuff we think matters, right? And so how do we make sure providers get ongoing sorts of support in using all sorts of different types of skills, whether that's the kind of core ingredients of supportive counseling, whether it's motivational interviewing, cognitive behavioral therapy, whatever, you name it. I don't see a way for us to put a world out there where therapists feel skilled in the practice that they happen to be using without giving them regular feedback on it. And so to me, like the first step is more, if we're going to be teaching people things in graduate school and there's a set of practices we want therapists to learn, because it's just kind of the things we do, right? These are the different, the 10 interventions we want you to do. We have to have a framework for actually teaching it to them, right? Like, and the way we do that now is we have you sit in a room, and this is what I got in a lot of my practicums at Wisconsin, is give me a lecture on CBT, show me a couple of videos, have me sit with a peer and practice it, a peer who knows as little and maybe less than I do about how to do it, and then go try it. And if you're lucky, you get some recordings and some feedback from a therapist or from a supervisor, but that therapist might listen, or that supervisor might listen to 10 minutes of that session, if you're lucky, once you get out of like a first year practicum. And that feedback might get to you 2 weeks later, month later, never, right? And people exist in a vacuum of feedback on their skills for the most part. And that's like in a training institution. Like once you graduate, forget about it, right? Mm-hmm. Like there's just nothing that allows you to create a learning context where you're getting rich feedback on your skills. And so everything we know about that suggests the only way we're going to actually help people maintain and grow their skills is by giving them feedback on them. And so go ahead.
But it's not just feedback, Zac, as we know from Anders Ericsson's work on expertise. It's feedback is important, but you have to have repetitive trials
Yes.
towards a goal for a specific behavior.
Right.
So the feedback, just feedback by itself, is not sufficient. So,
I have a couple answers to that. I agree. I would look at just take one evidence-based practice where we've actually, evidence-based treatment where we've actually studied it, done implementation work. So Bill Miller and other people have looked at motivational interviewing. You train people in motivational interviewing, you go into a workshop, they do a bunch of stuff. They've done implementation studies where they look at what happens if you just train people up, measure them for a couple months, and then you just follow them and measure them again in 6 months. You get this like that. Like literally their skills go up, then they come right back down to where they were before. Where if you give people some ongoing feedback on the skill they're using, just literally telling them, here's how many MI skills you use in this session, right?
mm-hmm.
You can maintain those skills over time. Right, people will keep using the intervention, and that's without these kind of directed practice experiences. But maybe it's enough that they already have them in an ongoing and like an initial training. So I mentioned that because I think one of the questions we're interested in at Listen is, if we go into a clinic and you're training people in all sorts of various things, and you want to actually not have that investment be like writing in the sand. You'd actually like them to be still using some of those things in 6 months. And we give you ongoing feedback. Do their use of those skills stay flat? Right? Do they actually still keep using them? And we've got some evidence that suggests that's the case. If we keep giving people this ongoing feedback, it's enough to support the maintenance of those skills over time because you're not going into a vacuum.
Zac, I find this a little discouraging.
Okay, how so?
In one way, that the goal is to keep the skills from deteriorating. You know, Anders Ericsson talked about expertise. One of the key aspects of being an expert is gradual improvement over time. You know, they asked Pablo Casals when he was in his 80s, best cellist player in the world, why do you keep practicing? I think I'm getting better. So it's discouraging to me to it's not just you saying this. It's discouraging that the goal is not to deteriorate. Shouldn't the goal be to improve over time, gradually, the way experts do?
Yes, I think it's a great point. What I would say is there's a little bit of a measurement issue here, right? Like, so there's a ceiling effect in some levels where once you get someone trained in a measure, in a motivational interview, and just take this because we're using it as a model. After training, they're basically doing the treatment, right, at a pretty decent level. And is there some room for improvement there? Yes. But it's the measure isn't necessarily designed or even targeting like Terry Moyer's style expertise, right? It's sort of like, are you doing it enough?
Yeah.
And it's a whole nother question to think about. What is this type of system we would need to not just promote like, oh my gosh, people didn't just go back to telling their clients that if you don't stop using, you're going to die. But they were doing, actual basic empathy and active listening and talking about change talk. What I think I would add is that at the same time, so Listen, one of our goals is to do this ongoing quality improvement. So, right, you've got measures over time of what you're doing, but we're also starting to build what I call like the beginnings of a training system that does a little bit of what you're talking about. Mm-hmm. So it says, here's a vignette, here's the skill we want to practice, do it, and you get feedback literally immediately, right? Mm-hmm. And so we have a training for motivational interviewing that is based on that way. It has, a 3-minute video on what a motivational interviewing is, and then it's like, here's the skill we want you to do, here's a patient, go do it. Mm-hmm. And then you get feedback on whether or not you did the skill. Mm-hmm. And so that is at least an avenue for ongoing development where the feedback is much more targeted to a specific goal. Mm-hmm. You could imagine those two things being used in conjunction, where if you had both things done at the same time, that maybe you would really see growth over time rather than just maintenance. I think the challenge really is, even I think our tools are really cool. I think they're a lot better than what's out there right now. They're pretty basic, right? It's like the basics of how to do an intervention, which I think most people almost really never get, right? You can go to full trainings on these things and really never get a lot of practice experience. But I would say I would agree with you in that it is sad. And if the main thing we did was to improve the bottom 5 or 10% of therapists, I'd be pretty happy about that.
Well, that leads me to where I want to go next, because you're alluding to the simulation you did. One of the things we collaboratively did at Wisconsin was look at therapist effects. How much variation is there among therapists? And we know from those analyses and pretty large data sets that there are some remarkably effective therapists who help significantly with almost every patient they work with. On the other hand, there were some depressingly poor therapists. I mean, one of the early data sets I worked with, there were therapists who never helped a patient, that every one of their patients deteriorated. So your simulation showed that if you took the bottom 10%, reassigned their patients to the other 90% therapists, there would be dramatically increase in the number of recoveries. So the question is this. We've talked about feedback to individual therapists. What does a manager of a system of care, a clinic, or even a crisis line do with the data that you're producing on quality? So how can it be used at that managerial level?
Yeah. To step back from that question, and I've had, I think we all in our careers have these moments that influence us to go in different directions. And for me, there's been a couple, when I was in my first religion class and realizing that we could think intellectually about all of these different religious practices, and that blew my mind, because a kid growing up in small town Oklahoma. And then there's the first time I read your book and thought oh my gosh, we can apply these statistical methods to understand these really complex theories. For me, where I was at the time in a master's program, it was kind of amazing to me that was something we could do. And then the next step for me was on postdoc, where I started listening to large amounts of naturalistic data from psychotherapy in the community and from these implementation studies. And I think I started to have some more empathy for some of the folks that I was arguing with in journals around implementing different evidence-based treatments, because it's one thing to sort of see it in the outcomes data, because you do, but then to actually see the variability in what the patient's experiencing when you listen to the tapes of really amazing therapists, just doing amazing work. And then work that was to the point where my research team thought we needed to figure out where this person was and call their supervisor.
Yeah.
Because it was potentially damaging. So harmful to people. And so I think that realization to me was a big part of why we got into some of this work. And another conversation I had with some leaders of large scale provider groups and insurance companies, where when we were first starting talking about, listen, one of their responses to us was, if you told me who my worst therapists were in my clinic, what should I do about that?
Yeah.
Because I need to hire 100 more of them. I can't let anybody go because they're not doing this treatment as well as I think they should. So you've got to be building stuff that helps people support the therapists they have, because we don't have enough of them. And if we doubled the workforce, we still wouldn't have enough of them. And to me, administratively, the way you would think, if we were to go into a crisis clinic, which we have, and say, we can provide metrics on empathy, active listening, risk assessment, safety planning on every single call that's happened in your center. What would you do with that? Their answer is pretty clear. Well, I'm already trying to generate that sort of data where I've got an entire quality improvement staff, and all they're doing is listening to calls, sometimes live, sometimes after action, and they can't listen to enough of them. And they take the literal call and they'll go to a clinician and say, hey, here's a call we had. It looks like this person was really in a lot of distress, and seems like this was some stuff that didn't happen. How can we support and do some practice so you can feel more comfortable doing that in the next call? We had another
Well, let's stop there for a second. So basically, what you're saying is we really have to put some effort into helping all therapists improve, but particularly those that we can identify as deficient in some particular skills, or maybe not deficient, but at least not using those particular skills strategically in every session. So our efforts are helping everybody improve. Now there's going to be a follow-up, but I want to stop there. So
yeah, yes, and I think that is important because this sort of stuff can be really reinforcing and helpful to people who are doing well. And sometimes if you know anything about like reinforcement, finding the moments when your people who are struggling are doing well is often the best way to help them do better. Mm-hmm. Right? So like if all you do is harp on like stuff that's not going well with people, it's really can be really hard to learn. So what you really want to do is find moments when they were doing the things you would hope they would, and reinforce them and support them, and find how can we extend this to other areas. And so but we have a dashboard in our software where we can show you literally every piece of data for your entire center, and there's a circle for every provider, and you can click on that and you can click any metric you want, so empathy, and you can see a full distribution of everybody in your whole clinic for empathy. And then you can click on the person who's maybe in the lower quartile, and then you see every client they've ever spoken to, and you can see that distribution. And then you can click on a client and see every session that client's had. And then you can click on a session and you can go literally to a moment in that session where there was an empathic moment or not. And so that level of kind of population-based quality improvement all the way down to a moment in a session was pretty impossible. Before.
It was pretty impressive. I still think I don't want to say technology, but the methods for helping therapists improve is where we need to put a lot of work. I mean, this is just absolutely awesome to be able to do what you've described. But we have to, in my opinion, take it one step further and say, okay, we've identified a particular skill that doesn't get expressed in a particular context. And now we have to develop some way to practice that skill, not just say, hey, next time you have that context, think about you should be empathic, even though this is somebody who just challenged you, to actually practice that. And I'm working on this with SkillSetter a bit to do this, because I think for me, that's the missing part, is the opportunity to practice in the way that Anders Ericsson talks about deliberate practice.
Mm-hmm. And then the question would be, I think that's our PhD program and our master's program use SkillSetter, and it's a really fun, helpful I can't imagine us not having tools like that for teaching counseling skills anymore, because we were spending a lot of time talking about skills rather than having people practice them.
And I remember, Zach, you came to me after using SkillSetter and said, I had no idea about the skill level of my students until I saw them on SkillSetter.
And it wasn't all that intuitive sometimes.
Yeah.
Right? Where you think, oh, these are the people who are highly skilled, I think, because of my impression of them. And it's a little bit like acting sometimes. I remember I had a good friend in college. He was one of the most kind of shy, awkward people you've ever met. And then you stick him on a stage and it's like dynamic, right?
Yeah.
And there can be something like that sometimes with therapists if you put them in the right context. But I think, how do we scale those sorts of things to where we're getting the practice experiences with the feedback, and like the thing that Tony Resmanier is doing with, really labor intensive iterative feedback with people on a very particular focused skill is awesome. It's really cool to watch. And how do we do that in a system with 3,000 therapists?
Yeah.
Right.
Well, that's the challenge to people like you, Zac, who have scaled up a lot of things. But we only have a few minutes left. I've got two areas I really want to talk about. So Listen is one platform in the digital space of therapy. Okay, we have all kinds of self-help, mental health apps. We have large organizations using telehealth, of course, guided therapies online. You can listen to virtual therapy, all kinds of digital solutions. You're involved in this space. What's the future of digital solutions for mental health, generally speaking?
Yeah. Well, it kind of depends on what you mean by future. Like what's 5, 2, 5, 10 years.
Yeah.
So I do think, because I'm in the middle of it, we have a future where it is going to be pretty normal and almost expected for you to get some sort of technology augmented support in your work, right? As a therapist, you're going to have AIs that are helping you write your notes. You're going to have AIs that are giving you feedback on your sessions. And those things are really going to be supporting the human therapist. And the initial ones will all be kind of ancillary to the clinical encounter, right? I think the near-term stuff usually will be about how do we make the therapist more effective, the human therapist? How do we take stuff off their plate that they don't want to be doing? How do we make training more scalable? All those sorts of things. What I think, to me, the next steps are, how do we augment the therapist during the conversation? The technology in a lot of ways exists for that now, right? So if I'm in a crisis counseling situation, why is it that I have to wait till after the call to get feedback on whether or not I've done X, Y, or Z, right? Why can't I get it during? Because that would be useful to the person I'm talking to rather than the next person, right?
Yeah.
And so to me, that's the next, if you went 5 years, that's where I would start to think about what's the user-centered design research we would need to do to make sure that sort of feedback or suggestions wasn't distracting, harmful, problematic, because it's the difference between monitoring a plane digitally versus having a bit of a co-pilot.
Yeah.
And how do we think about doing that? What are the tools? What are the differences in those types of tools? I think that's a really interesting piece. And then I think there is the emergence of like, what do the conversational agents look like that emerge in an ongoing way? And of course, we already have them, right? There's plenty of these sorts of chatbots that are out there right now.
Yeah. So by conversational agents, you're talking about a chatbot, a robot therapist. Yep.
Yeah, of some sort. And the ones you see right now, for the most part, there's exceptions, are entirely written by therapists. So there's AI in them, maybe around like, okay, I had a team of therapists and copywriters write all of these different things that my chatbot could say. And then maybe there's like an algorithm deciding, should this be shown to the client or that?
Yeah.
Often that's not even the case. Often it's forced choice. Like if the client says this, the bot says that, right? And it's just this very kind of And there's reasons why that makes sense, right? It's much safer, right? Where it's like, we have a human being who wrote everything that's got said. We know exactly what's going to happen. It is also extremely limiting. And people who use them often get frustrated with them because they're just not nearly as flexible and they're not human-like. And what you're looking for is a human-like experience. And so what you are starting to see, and there are examples out there now of some large language model, generative AI kind of chatbots. And those are going to be the ones that are potentially really, really cool and have the highest amount of risks. Because it would be similar if you were to go set up a mental health system for a place that didn't have one. And you were like, my job is to train all of the therapists and certify them who are going to provide care in this region. So I got to train 1,000 of them. And I'm going to try and make sure there's quality improvement strategies and ways of managing problems when they emerge or whatever. But how much would you be confident that there will be zero ethical problems? Zero statements said by that staff of 1,000 therapists that you train that were offensive to clients. Zero mistakes made. Well, you wouldn't, right? That's going to happen. You need to build a system that assumes that that's going to happen and have some accountability. That's not that far off from what we're looking at with generative AI chatbots. They are statistical models. There's probability estimates for how frequent different types of things are going to happen, and it depends. And you can prompt them in different ways, and you can get them to say all sorts of things. And so changing our expectations about, yes, we could provide care to an order of magnitude more people, but there are risks. Mm-hmm. Some percentage of those people will have a bad experience.
Well, Zac, I mean, let's be honest here. There's a proportion of people who have a bad experience with therapists. So, yes.
But it's the same thing, right? With self-driving cars, right? It's one thing to say, well, you get in a car wreck because somebody hit you. It's another thing when Tesla hit you.
Yeah.
Right. Yeah. And so, like, we're moving into that landscape. And so, what I don't think we necessarily have is an ethical or a regulatory structure for thinking about how to understand that.
Yeah, but there's another. Let's say I'm really interested in that because I've listened to enough therapy tapes to identify some very non-beneficial, trying to pick the right word, non-beneficial statements by therapists and non-beneficial strategies and on and on. So the fact that a chatbot or a conversational agent does this is well, it's different, as you say. When the self-driving car has an accident, it's different than a human error in terms of the public's perception of this.
Yeah,
but go ahead.
Well, and so that's one part of it, and then the other part of it is these language models are really compelling. They're really cool. They aren't human.
Well, yeah, there you go. Yeah,
like they're statistical models for predicting the next sensible word in a statement, giving prior training data. And
well, I think it's a bit beyond that too, though. Yeah, they're probability models, but our conversation here is a probability model in a sense. But the part that therapists think about, and I think about, is suppose my conversation agent that mimics me does a great job, but it's still not a personal relationship. Where's the real relationship? We know some of those human aspects predict outcome. They're very important. Will people accept a conversational agent that does a great job? It's like a Carl Rogers on steroids. This is a great therapist almost every time out of the box. Is it as effective as Carl Rogers in person? Because it's that interpersonal connection with another human being.
I don't know the answer to that question, and I think the the ways in which we're going to have to get at that question are going to be nuanced, because it's the same thing where it's like you could ask that question about telehealth versus in-person therapy right now, and the data basically says it doesn't matter.
That's right.
And I broadly agree with that. And I also, I haven't done a bunch of telehealth therapy. I did a little when I was in the VA, but I've done a lot of teaching online and I've done a lot of teaching in person. And I believe teaching online can be effective. And I hope I never teach another class online the rest of my life. Right? Like the first time I went back into the classroom and had 10 people around me that I was engaging with, it was like a drug. It was so much more fun than teaching online. And it was so much more engaging. And I think there is something that is difficult to fully quantify in that experience that may be difficult to quantify in what we're talking about here as well. And it may be that if you measure things in terms of just the alliance, like on a self-report measure, and the PHQ and satisfaction, they're going to look really darn close. Mm-hmm. And how do we characterize the differences between those things when our measures have so much error in them and they're so imprecise? And when if we sat in them experientially and we asked them, and maybe it could be a forced choice, which would you prefer?
Yeah.
And everybody's going to say, well, I'd prefer the human. Why? Well, I'm not sure what that answer is, but I think it's a really interesting research area. But I also think it is partially, it's an interesting one. And at the same time, most people don't get access to the person either.
Yeah.
And so we need to kind of put that question where it's appropriate.
Yeah. Access is the number one issue in the mental health system, not just in the United States, around the world. People who need help cannot access for a number of different reasons we won't go into. But maybe it's not as effective, but if somebody could use a conversational agent while they're waiting for therapy, might be important. So we have to think about this at a population level, not just an individual preference level. Oh, Zac, this has been tremendously informative and interesting. Your perspective on this and what you're doing at Listen, but your observations about AI, about language models, about psychotherapy, about how we can intervene to improve the quality of care is tremendously important. This has been a real kick, and it's so great to, see you again, even though we're not together. I very much appreciative of spending the hour with you.
Well, me too, and I hope it leads to an espresso in your living room soon.
Well, we can arrange that. We do have to get together. Yeah. So, Zac, thank you very much.
Awesome. Thank you, Bruce.
Thanks for listening. Making Therapy Better is brought to you by CarePaths. CarePaths offers a complete behavioral health EHR and practice management software solution, including claims, billing, clinical notes and documents, scheduling, and teletherapy, all for one simple and affordable monthly price. CarePaths EHR is HIPAA compliant and ONC certified, and can also support electronic prescribing for an additional fee. With CarePaths Connect, clinicians can enroll their clients in automated measurement-based care and create a digital front door for their practice. If you're just starting your practice or are dissatisfied with your current EHR, go to carepaths.com to start your free trial today. If you're currently in therapy and want to know how to get the most out of your treatment, check out the free Making Therapy Better app and visit makingtherapybetter.com.